My introduction is about impact of nutrition of patients admitted to the ICU and throughout the patient's journey in the hospital. These are my conflict of interest, consultations or presentations, and the outline of my introduction is talking about nutritional care in the hospital. What are main problems there? What are the problems on ICU? The problems of catabolic status, risk of overfeeding and refeeding, and what are the needs of patient and what is the reality we are able to give to our patients. What about discharge from ICU? Is this problem or not? Is this problem with nutrition or not? I think that yeah, because of risk of underfeeding, with lack of nutrition monitoring and low physical activity. And what about after discharge from the hospital? Are we able to follow up our patients with the nutrition? And what is necessary? I think that we will talking about cumulative balance of energy and proteins because we have to know how much calories and proteins our patient lose. So, what are the main problems on ICU? How much energy, how much protein every patient need? How much energy, how much protein are we able to give to them? And what are the intolerance of enteral nutrition? And this was the topic Professor De Waele will talking about. I think that there are 5 key problems of nutrition for critically ill patients. The first one is catabolism in the critically ill, but this is not issue of nutrition because catabolic status we must treat it itself, and we are not able to reach all energy needs and protein needs of our patients. The second one, during the acute phase, the measured energy expenditure should not be the nutritional goal because of insulin resistance, and we are able to measure it, but we are not able to solve this problem and take to our patient enough of energy and nutrition, but we have to know it and document it. Endogenous substrate production should be quantified, but this is very, very hard to quantify it. And any study design should consider biological and clinical data, and we have to be aware of rehabilitation phase about recovery of our patients. This slide is very known, so this is the phases of each patient's disease. In the first 1, 2, or 3 days is acute phase, early period with the catabolism, and then in the late period we treat our patients and their shift from catabolism to anabolism. It is our goal, but that could bring to us and to our patients some problems. In the late phase, we have to try to treat our patients, but nourish them, not only treat, but think about malnutrition that could origin during the ICU stay of these patients. And here you can see some guidelines for ICU admission for targets that are different in the acute phase, in post-acute phase, in post-ICU phase, and post-hospital discharge. And this is not my topic, this is a topic of each of our experts here. And we have to think about intolerance of enteral nutrition because we have some tools for it, and enteral nutrition is necessary, but some patients are not able to tolerate it, and this could bring 4 patients under feeding during the hospital stay. So the second phase is anabolic shift and the risk of refeeding syndrome, and we have to know about it, and we have to know how to treat it, and we have to be aware of not only energy need, but phosphate, thiamine, potassium and magnesium needs, and monitor it and apply it to our patients. So what are the phases? The first phase is critically ill patients with catabolism. We must be aware about overfeeding. There are energy needs, and we have to wait, but we know it, and we have to document it with cumulative balance of energy and protein requirements. Second phase, we treat our patient, we are successful, and during anabolic shift, the patients could origin hypopotassemia, hypophosphatemia, and mobilization of fluids. And during the long stay on ICU, the patients can have a decrease of nutritional supports because of problems with enteral nutrition, and we have to be aware about underfeeding. So this is the second stage, optimizing post-ICU recovery. And what are risky? After improvement of patient status and starting of oral intake, the patients start to eat, and there's no need of artificial nutrition. It's some myth of some doctors, some physicians. I don't say surgeons because Professor De Waal is surgeon, so I have fear about it, say anything about it. But mostly it's the problem that when if the patient start to eat, that no artificial nutrition is applied to these patients, and it is decrease of intensity of patients' nutritional monitoring and the finish of application of nutritional support. So, as you know, the patients can lose about 15,000 to 20,000 kilocalories of energy and about 500 to 800 grams of proteins. It is about 4 kilograms of lean body mass after 1 week on ICU, and we have to give back to our patients in the recovery phase. You know, Minnesota semi-starvation study, and during recovery phases, the patients needed about 4,000 or 5,000 kilocalories of energy to weight gain, not 2050, but 4,000-5,000, and that were health persons before this starvation in this study. So, and the last presentation will be about the problems of nutrition after discharge from hospital. I think, and not only me, but I am sure that Professor also, that is necessary to monitor nutritional intake of our patients after discharge from the hospital, and have post-ICU outpatient department and monitor these patients to improve their nutrition status. So, it's the finish of my topic, and I would like to ask Professor De Waal with her speech.